Giuseppe, are we ready to start?
Yes, we can start.
Okay, so are we online?
We are online.
Perfect. Okay, Manuela, to you.
Okay. Hello, buen dia, boa tarde, good evening or morning. I don't know where you are. Thanks for joining us today, attending our second webinar for Lipoedema Awareness Month. I'm Manuela Lorenz Barks. I'm from
del Portogallo e sono qui con Valeria Giordano e Marcello Zano per conto di Lipoedema Italia. Sono presenti anche Sherry Fester e Kate Foster che operano per conto di Lipoedema UK. Noi come associazione ci siamo resi conto che ci sono ancora molti punti critici nel lipedema. Come associazioni esperte di pazienti vorremmo contribuire alla diffusione delle migliori prassi nella gestione del lipedema e abbiamo deciso di riunirci e di promuovere trattamenti e informazioni adeguate attraverso questi webinar. Le associazioni, Lipedema Italia, Lipoedema UK e l'INFA Portogallo, stanno unendo i loro sforzi per organizzare una serie di eventi web congiunti per il mese della consapevolezza dell'epedema, destinati a essere trasmessi in live streaming su scala globale in diverse lingue attraverso i nostri canali di social media. I nostri eventi web sono resi possibili grazie alla generosità dei nostri donatori. Mi riferisco a Human Med, Giusio Italia, Medi UK, Solidia, Spese Medicali. Quindi grazie per averci ospitato e spero che gradiate il webinar. Ora passo la parola a Valeria. Grazie mille Manuela, sei incredibilmente preziosa, grazie davvero. Sì, prima di entrare nel vivo dell'evento vorrei informarvi, su alcune evoluzioni del movimento mondiale di difesa dell'ipedema, di supporto dell'ipedema, nato quest'anno per riunire i sostenitori dei pazienti con l'obiettivo di ispirare altri pazienti per favorire un empowerment affinché possano prendersi cura di se stessi e supportarli con la nostra voce. Quindi stiamo condividendo dei messaggi di advocacy durante tutto il mese di sensibilizzazione sull'ipedema e continueremo a farlo nei prossimi giorni, probabilmente mesi. Abbiamo proposto di fissare la giornata dell'11 giugno affinché divenga la giornata mondiale dell'ipedema, il World Lipedema Day, dato che finora non c'era questa data, quindi abbiamo pensato che, le nostre, gambe sono simboleggiate dall'1 della data 11, quindi per noi è il giorno più memorabile del mese per concentrarci su una parte così riconoscibile della nostra patologia e del nostro corpo. Ulteriori informazioni sul progetto verranno fornite nei prossimi eventi in futuro. Per ora vi invitiamo a visitare la nostra pagina web, la pagina Facebook, mi scuso, i gli advocate dei pazienti per il lipedema nel mondo, dove potrete individuare come aderire e far parte di questo grande movimento. Quindi ora entriamo nel vivo dell'evento.
Would you please introduce our speaker?
Oh, yes, with joy. It's an honor. Tonight, we are going to know about lipohyperplasia, obesity, and lipedema, and look into the hot topic of obesity in lipedema patients. Let me introduce you the author of a recent study about persistent lipedema pain in patients after bariatric surgery, showing that bariatric surgery used for the treatment of obesity does not cure lipedema, and even large weight reduction of more than 80% excess weight do not reduce lipedema pain. About Dr. Manuel Cornely. Professor Manuel Cornely is a specialist in dermatology and venereology, honorary professor of the University of Puebla for his services in lymphology. Founding president of the Professional Association of Lymphologists, He has been active in research since 1992. It's not yesterday. Developed the procedure lymphological for liposculpture by Professor Cornely TM initiated the paradigm shift on the previously only conservatively treated disease lipedema through the surgical treatment option. Professor Cornely has been operating regularly and continuously on lipedema or in lymphedema since 1997. With over 20 years of experience in diagnosis and treatment of lipohyperplasia dolorosa, lipedema, and as a team with well over 12,000 operations. Professor Cornely is highly skilled in the field of resective operative lymphology. Currently, Professor Cornely and his medical centers are leading the LipLeg study approved by the Federal Joint Committee of Doctors and Health Insurance in Germany, in German GBA Gemeinsamen Bundesausschusses. Professor Cornely lectures at many national and international conferences and congresses, promotes the interdisciplinary exchange of information between renowned specialists and scientists on all aspects of lymphology, with the goal of being able to pursue scientific questions in a bundled and competent manner and to work them up in a goal-oriented manner. Dr. Cornely, thank you very much for accepting our invitation. We are very happy and proud about it. So the stage is yours.
Thank you for this warm welcome to all you and all the guys out there in the world. We are looking today. I'm pleased to be your guest in this situation, and I just apologize my worst English. I'm German, so it's not my premier speech. So I hope everything works in the next hour quite good. So I would like to give you an information to this complicated word, lipohyperplasia dolorosa, obesity and lipedema, and what's together with all these things. And we start with the first slide, please. We will have three things to look on. It's the renaming of lipedema. I will explain this. We have to look on the LIDO, which is lipohyperplasia dolorosa, and obesity, and as well how to treat these diseases. Next slide. So why is it necessary to change the name? Because of the histology of the fat cells itself, because of the high volume transport insufficiency, and because of the lack of sharp changing edema in this disease, what you call lipedema. Next, please. Because of the pain, and go on. And because of these Babylonian conceptual worlds, with clear terms, there are no problems in understanding. That's a big problem in lymphology, and not only there. Next, please. So you'll remember the basic difficulty in lipedema is the deposition of an unusual amount of fat beneath the skin. Next, please. This was first written by Alan Hines in the... Return, please. This was first written by and published by Alan Hines in the 40s, and it directly attends the attention to the tissue where we are talking about when we describe the disease called lipedema by these first authors. Fatty tissue inflammation on the body, and so it's edema. The two internal medicine authors, Alan and Hines, source of cutaneous fat distribution on legs and orthostatic edema, and this clinical observation led them to the misnomer lipedema. Next, please. Here, typical clinical signs, stages 1, 2, and 3. Next, please. Go on. And the fat distribution disorder is genetically disposed, cannot be positively influenced by diet and exercises, as you all know. It forms symmetrically the arms and the legs, disproportional to the body, transvaselation, pressure painful, hands and feet are not concerned only in women because obviously its estrogen induced occurs. Go on, please. So it would be comprehensively and better characterized by the term Lipohyperplasia dolorosa, and I shorten it to the word Lido, so it's easier to speak and can be distinguished for the differential diagnosis. I published this in 2005. Go on, please. So let's have a look on these tissue, on these adipocytes. There are normovolemic small univocular fat cells, let's call them lipedema cells, and that changes the size of sharp extremities. It's pathognomonic for the lipedema. It is not, they do not occur in obesity. Go on, please. These hyperplasia of these adipocytes is characterized for lipedema, but the hypertrophy is it not. The original shape of the hyperplastic cells can change because these cells, these lipedema cells, can also undergo elementary hypertrophy. This elementary volume increase is reversible up to the original isoplastic volume. This cannot be reduced. Next, please. Here, typical histological founding. Go on, please. Now let's have a look, a deeper look to these questions. When we have a look to the gene expression of the profile of the arms and thighs fat with that of trunk fat. So we take probes from arm and legs and from the abdomen from the same patient, which was called a lipedema patient. It shows a different expression pattern between these fat depots. I would like to show you this. Next, please. And go on with the next slide. So you can see, next slide. You can see, next slide. You can see in the blue part, these are the cells which are from the sick, from the arm and the leg, and the red part, which are the cells from the healthy areas, from the trunk. And if you have a look on the left side of this picture, you can see as well that we can differ between arms and legs in the fatty and the adipocytes on lipedema. As you can read upstairs in this picture, it is transcriptomic signature profile. So this is what the cells, the adipocytes themselves, give out to the organ. We can really define which are the cells who are doing a lipedema and which of the cells are doing anything else, for example, obesity. These are very new findings from my colleagues from Leipzig. And Nono Anakam, she's written as an author in here. She has written on this going on. Next, please. So next, please. Lido, we call it Lipohyperplasia dolorosa, can also be combined with coincident hypertrophy of other adipocytes. We call them adipose cells. Next, please. So the way around to think, the hypertrophy is a thing which is characterized by Herpertz in 2021, and he wanted to show us these, but this disease is not hyperplasia. It is, of course, a hypertrophy which changes the silhouette of the body. Go on, please. There's a question to the pressure and painfulness of lipedema. There will never be a lipedema or lipohyperplasia dolorosa without any pressure. It's obligatory for this diagnosis. Go on, please. So the fat count distribution disorders are combined with a moderate and considerable tenderness, even on gentle palpation, please. Next. Since this symptom cannot be triggered, since this symptom, the pain, cannot be triggered on accumulated buttock or abdominal fat, the histological description of lipedema of the buttock is in today's reading not longer holds. Next, please. Already Wald, one of the famous guys beneath Alan Hines, published in 1949, pointed out that the painfulness can be triggered just on the legs, not on other regions or on the trunk, on its body itself. So the question is, there is a lipedema of the abdomen or the neck or somewhere else on the body without of the arms and the legs, is easily to answer. If it's not painful, it's not a lipedema. Quite easy. Next, please. One. Question, lipedema means fat and edema, water. So the question is, where is the edema? And there are no pathognomonic relevant sharp changing lymphatic edemas in Lidos. Go on, please. So surely the passive possible charge sharp changing orthostatic edema described by Alan Heinz is pathognomonical irrelevant because it is irreversible but not detected in all patients and not regular in all stages. Of course, it never occurs in the arms. So you have to quit this question, is there edema, but it's sharp changing edema, when you are talking on lipedema, respectively on Lipohyperplasia dolorosa, and this is the new name, just take no edema in there. Go on, please. The enlargement of the limbs is accentuated by orthostatic edema, particularly in warm weather, although rest in bed may, of course, cause some decrease in the size of the limbs owing to removal of fluid. Even prolonged rest in bed will not cause the limbs to become normal size. That is what anybody knows when he's talking on this disease. Go on, please. Go on, please. So, orthostatic fluid retention may occur in the patient during the course of the end of the day and may be resolved by positioning or bandaging. The underlying fat disposition itself, disordered by Lipohyperplasia dolorosa, is not influenced by this. Next, please. First keynote. Lipohyperplasia dolorosa, Lido, does not develop squeezable edema as it is common with the stages of lymphedema or possible with other edema disorders. Next, please. This binding of fluid in the interstitium is not clinically recognizable as sharp changing edema in Lido. This will be one of the most important questions for the next years. Where is this water going and how can we use to try to do anything good for the patient? He feels it as painful, as fluidful, as heavy legs, and this is why lymphatic drainage works. Go on, please. Are the arms affected in Lido? Yes, they are, surely. Next. Next. Alan Heinz overlooked the fact that up to 90% of the patients had as well arms like they are looking in this picture. Next, please. Next keynote. Next. Consideration to the pathophysiology, changes in the fatty tissue and affected patients leads on the correct name, Lipohyperplasia dolorosa, and we are worldwide renaming at the moment, and we will see it in 2023. This process of this will be closed, and which will be the new term, but I prefer this one. Next, please. I recommend renaming the disease and suggest Lido, as I told. And next, please. Next. The historical theme term lipedema should be understood as a misnomer, an inaccurate designation. Next, please. So in one glance, the misnomer we know, go on, please. So Lipohyperplasia dolorosa at the glance means beginning mostly in puberty, pregnancy, and menopause. This purported fat tissue proliferation, the extremities versus the trunk, collar or muff formation in the area on the joint regions, hand and feet not affected, feeling of heaviness and tenderness in the affected extremities, painfulness or on palpation continuously, increasing during the day, acceptable, applicable. There could be an orthostatic edema, hematoma, tendency, and Kaposi stemmer sign negative. And I think I do not need to explain what Kaposi stemmer signs means. Go on, please. Next, please. So this is typical sign of lipedema of the legs. Different sizes, different stages, but always the legs, 3 feet. And all these patients have the same, they have all pain in there and nothing else which leads us to the term lido. Go on, please. Next, please. So, second point, the obesity itself. Let's have a look at the fat cell. This is a typical fat cell, and the next shows us. Next, please. The normal fatty tissue might be the picture on the left hand, and the obese, as you know, every cell is growing because due to the diet mistakes and the non-exercising become larger and larger. Go on, please. So some definitions necessary to know. Obesity is a cytological hypertrophy. This means the cell becomes larger and its reducible cell volume. Next, the hypertrophy volume can increase and decrease. Next, so here we have a hypertrophy. It's an increase of cell volume. But the most important point is he has no pain. If you would have pain, you could think it could be a lipedema, lido, because the form of the sharp leads to these thoughts. But if she has no pain, she has no lipedema. Go on, please. Next. The obesity looks the same. It's an increase of cell volume and as well, no pain. And if you ask her, she says, okay, when I do my diets and sports, I'm able to reduce this cell volume, these fatty tissue in the arms, not in the legs, but I can do this in the trunk, for example. So go on. Next, please. Next. Stop. Herpens was the one who brought the lipohypertrophy, the body shape, into lymphology in order to get away from lipodystrophy. This was the wrong word, as it was, but it was a typical word for lipedema description. So he said, no, we should take a new word for this, but he specified it only not the cell itself, but only on the body sharp. This was the mistake. Go on, please. In 1995, he presented the solution for this reason to exclude the term lipodystrophy. I coined the term lipohypertrophy, which includes the increase of adipose tissue. Yes, but it has nothing to do with pain. In contrast to obesity, the increase in fat tissue in lipohypertrophy, this was its name, is always disproportional because the trunk remains slim. This is what we know from lipedema. Just go on. Next, please. In lipohypertrophy, Hubbard says, the predisposition-related increase of fatty tissue, there is a symmetrical thickening of the extremities, whereby the trunk is usually not affected, but the buttocks are also affected in case of thickening of the legs. The cause is relative endocrine deficiency. Next, please. Obesity, in example, hypertrophic fatty tissue does not hurt, regardless to whether the shape of the arms and the legs or the whole body have changed. Listen exactly, obesity does not hurt. Thank you. Go on next, please. The term lipedema as a somatic lipohypertrophy brings together body shape and the cell histology, and that confused. So it's not a good word to say a lipedema is a symptomatic lipohypertrophy. It should be not. We shouldn't take these words. Go on, please. Next. So just a simple illustration. On the left side, under A, you see it's an obesity, enlarged fatty cells. On the right side, you see small, normal volume cells, a lot in the same square size. Next, please. What do we call these? We call them lipohyperplasia. That's the right term. The cell count is high with the same unchangeable cell volume. So here's the clinical picture. You all know these, and it's called lipohyperplasia, and because it's an increase of the amount of cells and the pain, we call it lipohyperplasia dolorosa. And as I told you, lipohyperplastic cells are unchangeable, chargeable in cell volume. Go on, please. So again, an illustration, this could be lipedema cells, and sometimes they are able to have a volume increase. Go on, please. Next. And then we call it adipose lipedema. That's nothing to do with obesity. It's just that the cells from the lipedema can be larger and not larger, but at the end, if you go on to exercise them, then you will see at the end the same cell volume as you had before. Go on, please. Next. So, no, back, please back. Stay here, stay here. So you can have the coincidence, I'm sorry for the German words on this slide, the coincidence of adipositas, which is lido and obesity. It's in coincidence. It's not comorbid. It's not you have an obesity and it triggers you to a lipedema, which was written, as you know, in a paper from this guy, TB, to this Birch. It's totally wrong. Go on, please. Next. And you see the same in grandmother and granddaughter, for example. Here, it's a coincident adipose. The young girl has no adipositas at the moment. The age has an adipositas plus a lipedema, and both are genetic. Go on, please. Next. Next. We can go quicker here. Next, please. I showed you these, the transcriptome signature profile of the adipose tissue lipedema, as shown before in the works from Leipzig. And the next, please, we can differ between the arms and the fatty tissue and the arms and the legs in lipedema against all these other normal cells which are in the obesity. Go on, please. So we can clearly distinguish the adipocytes from obesity from adipocytes of lipedema, of lido in the transcriptome. That's nowadays possible. It was not 3 years ago. These are really new findings. Go on, please. Keynote. Lipedema fat cells differ substantially from fat cells in non-lipedema tissue. Necessary to remember this when we discuss later on the obesity. Go on, please. The lead cell in lipedema, lipohyperplasia dolorosa, is a hyperplastic cell, hyperplasia. The extremity fat on the lido patients is of special quality, as it is a tissue formed that is not increased in volume but in number of cells. The hyperplasia of adipose tissue cells, cellular hyperplasia, can be combined with a hypertrophic fat cell, which is obesity. Go on, please. So again, the summary, we have to differ between a lipohyperplasia, an obesity, and a hypertrophy, and next, the hyperplasia dolorosa is a symmetrical increase of number of cells which cannot be reduced, which cannot be reduced in number or volume through diet and exercises, or the dynamic progressive tenderness on the extremities. We see later what I understand under dynamic progressive. Go on, please. No pain, no lido. Very easy. Go on. The painfulness at lido is from the clinical experience. There is a connection between the effects of the CDT, of manual drainage and compassion, and the improvement in pain. The painfulness is obligatory, the diagnostic criterion. The pain eludes an effective analgesia therapy. Next, please. There is obviously no relationship, and that's necessary to remember. There's no relationship between the volume of the fat layer and the prescription of tissue pain. You all know enlarged stadium 3 lipedema patients with small pain, and you know these tiny lipedema layers, stadium 1, with enraisement of tenderness and pain. Next, please. So what I will point out is it's not coming now. Just next, please. You see the pain starts somewhere easy in the puberty, for example. Then it's growing up in the years you live, and it's coming more and more. It's what we call it's dynamic. And so if you have a good examination of the anamnesis of the patient, she will tell you that the beginning of the pain there was some pain on Monday and Tuesday and nothing on Friday and Saturday. And this followed in the next week the same way. And the weeks coming and coming, it will make more pain on more days, for example. But at the end, she can tell you that nowadays, looking back 20 years ago, for example, the pain 20 years ago was not so much pain as it is now. So it's a dynamic, growing in frequency and amplitude, as we showed in this illustration. Next, please. Hyperplasia dolorosa, the lymphatic vessels are intact and fail in their transport capacity in the long term, leading to a dynamic worsening of high volume transport insufficiency. The increase in pain is this condition is progressive in frequency and amplitude. What do we mean with this idea? Due to the fatty tissue distribution, it's genetic and you can't change it because it's the same as you have 2 ears and 2 eyes and a nose and 1 mouth. That's genetic. But in this fatty tissue, the second part, for example, of this disease is the lymph, which is produced more than you can transport out of this with your normal working vessels. We did these findings in the 70s of the last century. These are old things, we know it. And we can show that it is becoming more aged patient, they have a worse transportation rate. So the capacity is, from the beginning, is quite good, but becoming older, you have to have a higher transportation rate, and this is an insufficiency, where we are talking on the transport insufficiency from the lymph. So always a little bit of lymph will stay in the tissue areas between the fatty cells. That's the fluid which is between and bounded in critical canes, and so the tenderness and the pressure will go up and it will become more and more and more, and so you feel more pain. This is the idea we have at the moment. When we are doing surgeries, we are doing science exactly in this question: what does the pain belong? What's behind the pain? And can we find any protein which belongs to this pain to change it? Go on, please. Next. The increase in pain is a condition. In this condition is progressive in frequency and amplitude. This is one of the best keynotes. And the next, please. Sorry for the non-translated slide. I had a mistake in my translations. In there is written that the pain is a cardiac obligate syndrome in Lipoplasia dolorosa, arms and legs. There's no lido without the pain, and it discriminates the lido from all the other possible fat distributions, which are symmetric but without pain. In example, obesity. It discriminates the Lipoplasia dolorosa from the adipositas. Next, please. So, diagnosis Lipoplasia dolorosa, it is necessary that, go on, you prove the symmetry fat distribution disorder in the extremities through the disadvantage of the trunk. You ask for resistance to diet and exercises due to the genetic predisposition. You prove the question of painfulness, and I will show you how to do this. And you ask for the increase of vascular fragility, you know, these hematomas. Next, please. Next. For the diagnosis of adipositas, you have to prove the symmetrical fat distribution disorder in the whole body. And we have no resistance to diet and exercises. We have no painfulness, and we have no increased vascular fragility. So you see, there's a big difference. Just go back one slide back. Can you go one slide back? Yes. And you see what I did? I just changed the headliner from adipositas to hyperplasia dolorosa. And here you can prove what is typical for a lido. And now get the next again. Next. And then you see next. Then you see that in obesity, you find necessarily other points, no resistance to diet and sport, no pain, and no increased vascular fragility, and surely the whole body, not just the arms and legs, but as well in adipositas, you find this in the arms, the legs, the tummy, the abdomen, nearby the neck, and sometimes the hand and the feet. So go on, please. We can go on further. Next. Adipositas is no trigger for lipohyperplasia dolorosa. Both are not comorbid but coincident, and surely the adipositas is not the baseline illness for a lipohyperplasia dolorosa, which was written in an international committee. You know that we have patients with lido in stadium 1 and stadium 2. They are normal and perhaps low weighted. It has nothing to do with obese. Come on, please. Next, the obesity, that's the next keynote. I'm sorry for the German. The obesity is a lonely standing illness, disease, and we have therapies for treating it. And the obesity is coincident, not comorbid. And if you treat the lipohyperplasia dolorosa, you can do this. And if you treat the obesity with bariatric treatments, you will not have good effects on the lido as well. I will show you afterwards. Go on, please. Next. I'm sorry for this not translated pictures. Even the next are not translated. I'm sorry for that. I had a mistake in my work. When I was in Assisi, I did this presentation and it was midst the night. And I think I had a little sleep too less. So I want to show you how to examine what's a lipedema. I want to show you what is necessary to see it. And even you will see afterwards, you can do the exercise in yourself. Go on. How to examine the patient for lido. Next, please. Next. The first, you have to do an inspection from the distance. The second, you have to do an inspection from the near. You see this collar region, for example, in the feet. Next. Then you have a smart look to the feet itself. Necessary, you see that you have no edema in the back of the foot. You see the stammer signs negative. This is the third picture. And you see that the collars of biscard in the backside is filled up with fatty tissue. Sometimes you see this collar sign. Next. Sometimes you see fatty tissue as well. In this region is medial proximal and the low leg, and it's painful as well, as we see in the next slide. Go on, please. And then you have to do the palpation carefully. Never pinch it. Palpation means that you have a very soft and smooth layer, the hand on the fat, and you just bring a little bit pressure into the skin, not much, just very superficial. Next, please. So the first palpation you always do on the inner thighs and the lower leg down there. The next is next. Outer thighs, both. Next. Then you have a look to the arms. You see the caliber, the muff collar in the arm as well. Next. You turn on the back side of the patient. You take both arms and give the palpation there. And you always ask, is it painful? Yes or no. Just yes or no. not begin to explain me what you feel. You just ask, is it painful, yes or no? And she says, yes, I don't like it. That's enough. And then next picture. You take your, in this part, right hand, bring it to the abdomen, and the left hand and the arm, and you do the palpation on the tummy, and you say, okay, it doesn't hurt, nothing hurts. And when you do it with the same strength in this way with my fingers on her left arm, she will say the arm is painful and the abdomen is not painful. So it can show in only one patient, individual, to her that she has a painful fatty disease in the arms and the legs, and there's no pain up the abdomen. So this you will never see in a obese patient. You'll just see this in lipo patients. Go on, please. Next picture. Next picture. Next. So we are hurrying up quickly how to treat. I would like to show you what we can do with Lido and what we can do with obesity. Go on, please. And what we can do with the combination. So the therapy is the same for all the stages of Lido. It's operation or manual drainage, CDT. Go on. Please, all you listeners, Lido patients are often dissatisfied and disappointed. Why? You know this well. You know everybody is talking to them, go on more exercises, more diets, do more sports. And you did any exercises and sports and anything, and you feel they do not believe you when you say, I did all this. So, dear doctors and dear patients, listen exactly to what they tell you and tell them that it's an unborn genetic disease. You are not to blame for your lymphologic disease. You have done nothing wrong. This is up to the leaders. When you're talking the same sentence to the obese patient, that's wrong. Obesity is something which is genetically, as well genetic, has a genetic principle, but it always goes together with too much meals and less exercises. You will never see an obese patient without this problem. But this problem is not the problem of Lido patients. So carefully take this in other decisions and do not blame them. There is nothing to suggest that initial physiological, but everything to suggest a biological, lymphogenic course of the pain, triggering, and sensation. Next, please. Keynote. The number and size of hyperplastic adipocytes in Lido remained unimpressed, the same by conservative treatment. Next. So I would like to show you what's up with the surgery. We call it lymphologische liposculpture or lymphological liposculpture in Lipohyperplasia dolorosa, and I show you a state of my art. Go on, please. Next. It's a part of surgical measurement in Lido that is successful by using two steps. There's one step, the fat removal, and the second is training the lymph vessels. As you remember, the background is fatty tissue, you have to take it away. And the second is that the lymph vessels do not accurate work, so we want to train them. The aim of the procedure is for patients to be afterwards symptom-free post-surgical, post-therapy, and not required further treatment. This is what we always is our leading aim. No more further treatment. Next, please. The foundation of the paradigm shift was the resecting procedure has been studied by me for use in lymphological indications, and 140 Lido patients have been used to test these effects in me, and they did this in 1998 and so on. Go on, please. Here you see me years ago, the cadaver in the anatomy of Innsbruck, And we trained this surgical technique in how to suck the fat without killing the lymph vessels. And you can see here Professor Brenner is in the middle, the man in white, and he is the anatomist, and they did the preparings of the lymph vessels, which is shown in these little parted pictures in this enlargement. Go on, please. Next. So, taking the possibilities of sucking fat in account and changing them a little bit and modify them for the questions of lymphatic diseases, we use the Tumescence local anesthesia, and now we do the resection of treatment subcutaneous tissue by suction for those three medical indications: Lipohyperplasia dolorosa, cause lipedema, primary lymphedema, and secondary lymphedema. Go on, please. The procedure is performed in 2 steps, as I told you before, the fat resection and the subsequent lymphatic vessel training. It's a complicated name. It's called supraphyseal subcutaneous subtotal aspiration vibration exaresis, easier as lymphological liposuction, with a system which is called micro-AR system, Tumescence local anesthesia. Its acronym is PTLA. In the case of lymphedema, we add to the LA as well hyaluronidase, and afterwards, necessarily, we have a post-surgical, post-operative extended manual drainage as lymphatic vessel training, shortened MLLD. Next, please. So just short look to these surgical rooms. You see here the guy working in the inner thighs of the lipedema. Go on, please. Next, please. The arms as well, completely done. Next, please. And at the end, you have to see how thick is the skin. In lymphedemas, you cannot take the thickness out of the skin because it's typical for lymphedemas. In lipedema, you can smoothen the skin afterwards, as you can see here, and you have to go with this cannula, seen on the right hand, indeed completely under the skin. This is forbidden if you do a cosmetic surgery. Then you take just the middle layer of the fat away, but in lipedema, you have to take the fat completely away. If you do not do this, you have not a recurrence of lipedema, it's just bad done. When you do the job the correct way, you have to treat it completely. Next, please. The amount of tissue to be sucked is limited of 8 liters per case. In a few cases, up to 10 liters per session. So up to we take 3 sessions. Even in these dimensions, no hazards are to be expected from lymphological liposculpture. The surgical procedure takes place under anesthesia, local anesthesia for the fat, and as well as general anesthesia, if necessary, only under deepened analgesia. But in our concept, always done with an anesthesiologist. Volume balancing, cardiovascular, respiratory, and CNS are under special control during and after the procedure. Always 2 doctors on the table. Next, please. And this is what it looks. The aspirate is done with a negative pressure. And at the end, you should have the tubes completely full with colored. A gentle aspirate should be orange, the ridge. But sorry, but it looks a little bit like, the color is a little bit like Campari Orange. Go on, please. Next. What are the results of the application of lymphological liposuction and Lipohyperplasia dolorosa? It has to be eliminated, the painfulness. That's the most important thing. Several successes are reported in other working groups that certainly treat lipedema, Arch, Rapesh, Bonina, Santov, and others. One, please. Surely we have a question to the quality of life and the pressure pain after surgical treatment. The improvement of quality of life has been proven over several times. That's worldwide now. That's nothing new. And now we are working on the lipedema study. It was told in the beginning of this evening, which was launched in 2021, as a trial to test surgery and conservative treatment in relation to changes in pressure, pain, and lipedema are not expected before September 26. Come on, please. In our own experience, after 8,500 performed procedures, nowadays these are mine, but well, indeed, we did with a complete team up to 12,000 procedures. We aspirate between 500 CCR and 10,000 per session with the same result. Through the successful application to the surgical procedure lymphological liposuction, the master thesis of the high volume transplantation and sufficiency rate as a pathognomonic principle was verified ex vivo. Means we take away the fat, we bring the lymph again to a normal and better flow condition, and the patient feels no more pain. That's indeed what we need. And if he has no pain, he does not need any lymph drainage or compression stockings. Go on, please. Next. Studies of the 140 patients at first reported in 2005 with these results. We did the same in 2012 for the publication on 600 patients after 15 years, and there we had a good number of 79% of the patients were still symptom-free after 15 years and did not perform any further CDT. This was exactly what we wanted. Recurrences never were reported. One, please. Next. At the glance, we can quit this. Go on, please. Since Lido is congenital, in example genetic, and not acquired, unlike obesity, fat tissue distribution disorder, the results are stable. Necessary to know. It is an amputation of fat. It's not a smoothening of legs or arms. It's nothing to do with cosmetic. You have to take it completely out of the tissue. Go on, please. In addition to a classic diet, 2 surgical measurements are available for obesity, the Roux-Y gastric bypass and the sleeve stomach. For weight reduction are available. Go on, next. So let me show this example. Very interesting characteristic. Before the stomach operation, this young lady had a height, as always, 172 centimeters and a weight up to 167 kilogram with a BMI of 65.4. These lipohyperplasia on arms and legs had a 0.5 on the visual analog scala, which is, as you know, the scala for the pain. So you would see this patient and you would always say, she is obese, and when she is painful, she is obese with, and in a coincidence with a Lido. Next, please. Same patient, 8 months after the surgery in the abdomen. You see she lost really weight. She has now 115 kilograms. The BMI is much more better. We measured the waist, hips, and the HTR. But she has persistent lipoplasia dolorosa, pain in the arms, more than before with a VHS 8. And again, a few months later, next please. Same patient, 20 months after the stomach surgery. She looks nice and fine. And normally you would say, what's that? Her tummy is slim, but she has something with legs. What has happened with her? She has still the Lido on arms and the legs after the surgery in the abdomen, in the tummy, and she has still the VHS from 8. So necessarily, now she needs to have surgery on the arms and legs to remove the rests of tissue, which are only lipedema tissue, but is still now there. She's a very typical example for what obesity can be treated, in this case with a stomach OP surgery, and that this surgery has nothing to do with the change of the pain in the lipedema. This is necessary to know, and I know this is a point of discussion, but with me there is no just gentle discussion, but not a big one. If you want to treat a lipedema, you have to treat the pain. And you can do this with manual drainage, compact stockings, or complete surgery in the arms and the legs, and not on the abdomen. One, please, next. This patient here continues a requiring daily congestive therapy with manual drainage and compression to treat the pain. So subsequent lymphological liposculpture will remediate the coincident lido. Go on, please, next. The pain symptoms, that's a necessary keynote. The pain symptoms of lido are not improved by bariatric surgery. You will never change it by bariatric surgery. Next, please. He published this in the paper of the persistent lipedema pain in patients after bariatric surgery in case study of 13 patients. This is one of the largest papers in this question. And all others before, Pauls, for example, and some others, had up to 3 patients, something like this, and no before and after. We did it completely with the group in Cologne at the research. My group, Vittel Hasenberg, is the bariator, with the guy Oliver Cornely is a brother from me, Christian Uwe from Austria, Hettenhausen was a co-worker with me, and the other Niels Schmidt is from Potsdam. So if you're interested in, you find this paper, and I'm sure that the Valeria can give you this DOI number as well. Next, please. So what we do today, just have a smooth look on this. If you have a weight less than 120 kilos and less than 40 BMI, we take you direct, and the lipedema, we take you directly to a lymphological liposculpture in Germania. If you have a weight more than 120 and BMI more than 40, we first try to train you down under 40 BMI and then take you to a lymphological liposculpture. And if it's impossible to do this after 6 months of diet and exercises, we'll bring you over to Hasenberg, to Clerk Hasenberg, to ask him to have a bariatric surgery as well, so that we can have the better conditions to do the surgical way of Lipohyperplasia dolorosa done by the Lipohyperplasia dolorosa done by the surgery way I told you. We do it this way because this is covered by insurance companies at the moment in Germany. So I have lots of patients coming to me and say, "Doctor, I would like to be healed in obesity and in lipedema both. If they have the right weight, down 50 BMI, they can do it directly. If not, we first have to bring her in better conditions due to the BMI. Go on, please, next. Since the weight of the fatty volume is equilibrated in connective tissue, lymphological liposculpture sees a reduction in the circumference of the extremity, but no reduction in the weight of the patient. Just remember this. We never do this surgery because we want to bring you in a better way to smoothen your legs and arms. What we take out will be filled up with connective tissues. And nevertheless, the practice shown that desired weight reducing is easier to achieve postoperatively. I will show you why. Go on, please, next. Here's a young lady. No, return. Return the picture, please. One more back. One more back. No, other way. Not forward, backward. Back. Stop. Next, please. just a picture. Next, please. This was also in this case by the patient. At a height from 1.68 centimeters and a weight of 95 kilograms with a BMI from 33, obese type grade, the patient presented with a Lipohyperplasia dolorosa stage 2 of the arms and legs with a pressure pain score of 7. Next, please. In 3 sessions, we removed, as you can see, on the outer legs 5,000, on the arms 2,2, and in the inner thighs 6.5 liters from the legs. In summary, it was 13,700 milliliters of fat tissue removed, weight of 0.6 kilogram. The post-surgical cavity on the extremities implied that fat fills of connective tissue. The initial weight remains stable, which was exactly what we expected. Next picture. Now this young lady did diet and exercise, and she is not typical, but I want to show you this. Diet and exercises after we did the surgery in the Lido, and the patient succeeded, plus losing 32 kilograms. This is not normal. On representation, after 1 year, the patient was completely symptom-free. She was symptom-free in the arms and the legs due to the pain directly after the surgery. But now she reduced her weight dramatically, and she became a sports lady. Next picture. And this is what she looked afterwards. Yes, you see the difference? There is no lido, there is no obesity in the tummy, and she felt fine and she had no more pain. Next, please. And here, before and after, I think it's really typical. On the left side, you see her sitting as a lipedema patient with obese. It's in the summertime, and she's covered with clothes and sitting on this small animal, which is normally moving slowly, and it has this what we call curtain, this shield to cover from everything outside, which could damage her soul and her body. And on the other side, on the right side, you see she solved the problem. She solved the problem with lipedema. She solved her problem with the obesity, and she began a new life. Indeed, this is an example which is not normal, but all my patients I saw in the last 25 years had a change of their life after the surgery of lipedema and the reduction of the lipedema, the complete going away of lipedema when you treat them correctly in all those things I told in the last hour. Next, please. So, lido and obesity, what therapy is appropriate? The following 3 statements fully capture the issues in lido and coincident obesity. The lipedema-associated pain symptoms appeared to be independent of the weight. Yes. Physical activity and diet changes can reduce obesity, cannot eliminate the disproportional fat increase in the extremities caused exclusively by lipedema, or better called Lipohyperplasia dolorosa patients. Third, the lido patients, coincident with obesity, there is no effect of gastric surgery to the painfulness of lido. Next, please. The volume reduction of arms and legs due to the bariatric treatments can be seen, which is caused to a reduction of the volume, but not to the number of the lipohypertrophic adipocytes. Since from the dermatological, lymphological point of view, it is established that lido is not a particular form of obesity, no improvement can be expected from gastric surgery. Next, please. Gastric surgery, wherever sleeve or exclusion rule bypass is the maximum dietary option, but cannot achieve the goal for any therapeutic treatment of Lido, a sustained improvement in the pain. Next, please. So, last key point, Lido-associated pain symptoms appear to be independent of weight. Next. The physically activities and dietary changes can reduce the weight, but they cannot eliminate the disproportionate fat distribution proliferating in the extremities caused exclusively by Lipoplasia dolorosa. Next. The patients consider with obesity, there is no effect of gastric surgery in painfulness to Lido. Next. One sees the volume reduction in the arms, and legs due to the bariatric increase reduced in the volume but not in the number. Next, please. I think we had this, it's doubled. Next. Next. Lipoplasia dolorosa cannot be cured by the surgery of the abdomen, although the patients in the study lost an average of more than 50 kilograms of weight. They displayed no improvement in the pain symptoms typically to Lido. Next, please. So this is the last. The most important result of consistent surgical treatment of Lipoplasia dolorosa is the influence of the quality of life. It was Ellen Heinz in the 40s who said it ruined her life. And I said it improves her life when you do it by surgery. So thank you very much for listening me to this terrible English. Bye-bye.
Thank you very much.
Discussion.
Thank you very much. It was an amazing presentation, a lot of take-home messages.
Yes.
We are kind of, I can define it. So let's start with some questions because actually I have a very complex question for you. So sorry in advance. I do apologize because I'm concerned about genetics in this. Because you know that we as Italian have a study in which it was discovered that a gene mutation of the gene AKR1C1 as the first candidate gene associated with non-syndromic lipedema was actually associated with a family in which there was no pain. So the first question is, do you think that pain is so mandatory to have a diagnosis of lipedema? And furthermore, if you have a controlled patient with lipedema, who had undergone some surgical procedure, who wears compression, does proper nutrition, etc. So it has the pain in control. Do you think it is always lipedema, beside the fact that the patient has control? And so it's a complex question because it involves genetics, it involves a lot of things about this, because the main issues can be how significant is for you the latest genetic discovery for future treatments.
I'm just, as you know, anything on lipedema, or let me say it, on Lido. I love it this way. Okay. Anything on Lido is at the moment work in progress. I'm now doing science since more than 25 years on this theme, and I'm really glad how many new colleagues are in this field working worldwide, so that we get more and more information. We are not at the end of all, but at the moment, for me, it's very clearly to decide that the lipedema is always what I just told now for an hour. It's fatty tissue, it's in the arms and the legs and nowhere else, and it has to be painful. If even the word what means pain is complicated. Pain does not mean you take a knife and bring it into the skin. Pain is sometimes like a heaviness, like feeling it's too much weight. something like this. That's not so easy. And sorry, and we have to find out a solution to have a better description of these, for example. As you know, there's the Inuits have 23 names for snow. We need some more for pain, and we need to describe this exactly. But I want to take out very clear that there is, whatever you call it, it's not a lipedema if it has no pain, or it is a very good treated lipedema. If you treat it very well, the pain is going. But I do not agree, even not with Karen, that there could be a lipedema at the abdomen, part one. Whatever they found in the genetics, I love it. But it's not a lipedema for me if it's not without pain. And that was the same I told to Sandro Michelini to his study when he said, okay, we're studying lipedema, but 20% had no pain. Said, okay, then it's a study just with 80% lipedema. The rest is anything else, but not lipedema. So this is a question of the diagnosis, and we have to accept that the combination of pain and fat is called lipedema. And then you maybe find anything else in fatty tissue diseases. Can be anything, but not lipedema. So you have to be clear in these things. If you worsen the terms, you will have no clear discussion at the end. And that's the big, big problem. Remember all these ladies which are obese, without lipedema, without pain, and coming over the street and say, oh, I have a lipedema, this is why I cannot reduce my weight. That's nonsense. You have clearly to say that's obese, that's not obese, that's a lipedema. Or a lipohypertrophy, which is as well a much volume on fat, but it doesn't hurt.
Thank you, doctor, for this answer, because this is exactly what we want to enhance, to stimulate discussion and different points of view from one professional to another, according to your research, to your experience. So thank you very much for providing a different opinion about topics that we discussed maybe in the last webinar with Karen Herbst. Thank you very much.
You're welcome.
Do we have other questions, ladies?
Yes. During the presentation, you talked about many arguments, so we could make 1,000 of questions, but I think we reduced.
Sure.
It was very inspiring in any case. And a question that we received, it is if the lipedema is always progressive. Because a lot of ladies try to make a lot of sports, follow suggestions about sport, nutrition, and so it must be always progressive?
No. I described two parts of this disease. The one is due to the fatty tissue. The other one is due to the pain. So for me, in my thinking, you will have a progression in the pain. This is due to becoming older and due to the capacity of the lymphatic drainage, high volume insufficiency, which is a question of becoming older. That's normal. But due to the question of the distribution of fat, this is genetic. You all know ladies which are 20 years old with slim legs, and they have the same slim legs when they're 82, and they did nothing else than to live. And you have these ladies which are 20 years old with maybe slim legs, and then they are 40 and they are fatty legs. So I always tell to my patients, when you want to know from me how well I look in 20 years from now, I just ask them, do you have a mother or somebody else? Do you have a mother? Sure. In
any case,
do you have a female part in your family, mother's or father's side, both, which has maybe the same composition of the body? And did she have something which was a lipedema? She's looking like you. We call it eine Blaupause. It's the plan, the biological plan. Maybe you speak German. What is Blaupause in English? I don't know.
Blue
break,
sure,
blue
yeah.
flame. I just translate
Yes,
verbally.
So this would be the way you will become. If you do not believe, just look yourself in your mirror, and for example, look on pictures 20 years ago. Then you know you are moving forward. That's very normal. We call it life. That's normal. So this is not a progression. This is just living. So it might be that we stay with your slim legs from the 20s up to the 80s, and it might be that you have a so-called progression, but it's not a progression, which is just going on running. The only thing you can change as a female is to be pregnant, become pregnant, and you can change, for example, your body shape, and you can change your body shape with diets and sports. That's it. But that has nothing to do with the word progression. It's again such a very good example how we have to have very careful look on the words we are working with. Progression in medicine means always becoming worse, but it's not becoming worse when you are living. That's normal. Becoming worse is the pain, which is becoming more and more in frequency and in frequency and amplitude of the pain. Did I understand what I mean?
Yes.
So lipedema, for me, in my speak, has no progression. The progression is progression of the pain.
Okay.
And we do not know how to treat this. As you know, we have no medicaments. There are no medicaments working, not really working. And we have nothing done in search in this question. Just look around. Where do you find the works, the international works, on what is with this pain? What is it, this pain? You will not find a pain science on this question. So we are doing this in Cologne University with Professor Hugo since a few years, and try to find answers, not to find a medicament, something like this. We want to know what is behind this expression pain. What does it mean when you are touched and you feel it's not nice? And then maybe we have the solution. But it's typical, again, we'll find this typically only in lipedema. Only in lipedema on the arms and legs, and not in the obese. That's the point.
This is super interesting, Doctor. We are overcrowded with questions
Yes.
all over the world. So we have 10 minutes actually before the end, but we can take 5 minutes more because we just started a little bit later. So I have a question because my former question came from Italy, but now we also have our friends from the UK, Kate Foster and Sherry Fetzer, who are monitoring.
I apologize, Sherry, I apologize my English.
And mine too.
Okay, come on.
Don't worry, Doctor, your English was super perfect.
No.
And we are all very international here.
Yes.
That's good.
So we all know that Sherry will approve your English, definitely. So now in this moment, they are not concerned in language issues, but on monitoring questions coming from UK, that of course, there have been raised a lot of questions whether liposuction for lipedema is always safe and when it's recommended, because and I would like to ask you your view on patient situation in which you would not recommend liposuction because it is intended not to be safe.
Yes. I know this discussion from NICE. Sherry, thank you very much for your question. I do not agree with NICE. We have much more results to the safetiness of this surgery, and they are all published. But unfortunately, the most of them are published in German, and the Institute NICE did not read them. They didn't want to be interested in these. But this surgery is carried out now, for me personally, since 1997. And I did roundabout with my team 12,000. And I would say we had a small amount on thrombosis. It was 0.007. And we had a small amount on infections. This was 1%, 1.2%. That's nothing. And if you have a look to the safety of tumescence anesthesia liposuction. You have to differ. You're talking tumescence anesthesia liposuction, and you just look to the very, very good work from William Henke from 1993. He had more than, I think, 50,000 surgeries done, liposuctions in cosmetic questions, all over the body. And they had, this is published in 1993, 19, I don't know. I will send it to you, Sherry.
Wow.
Indeed, no problems, easy tell. If you have to see a few things you have to do, not go over more than 10 liters of tumescence, not go over more than 2 liters, 10 liters of tumescence, not go over more than 10 liters of fatty tissue removing. That's the both things you have to look for. And always take into account you should have 2 doctors on the table, a surgeon and an anesthesiologist. Next question.
Well, I don't know if I can ask. We have first of all, Sherry said that she's very sorry because she cannot understand German or even read it. So stay calm with your English because your English is just perfect, okay? And that's
Sherry, it doesn't matter. I will send you these works translated.
okay.
It can be translated by people, professional.
But we have also a question on the Facebook. Someone is asking, does still recommended liposuction if someone also has lymphedema?
Yes, I do. The combination, it's a combination of 2 diseases.
Okay.
Primary or secondary lymphedema, both possible, and a lido.
Okay.
My first patient in this question was a lido patient with secondary lymphedema of the arm after breast cancer. And we had the same suction that you have told today with a very good result in the lido and an even very good result in the secondary lymphedema. We are doing the surgeries in secondary and primary lymphedemas as well. Okay. The idea is to remove the subcutaneous tissue completely, which is not so easy in the secondary lymphedema. That's another point, because it's not fatty tissue, but proteoglycans. But it doesn't matter now. Both is possible, and it is not a problem to do the surgeries in these as well. But please be sure that you know what you are talking about when you say it's a lido plus lymphedema. Okay. You need to have a better, you need to know which kind of lymphedema is in this lady. Is it due to an obesity, which is mostly happened? It's a secondary due to a cancer, for example, or is it primary? It's an unborn. You should know this before you do the surgery.
Thank you.
You're welcome.
Sherry tells us, please tell the doctor you're my hero. Thank you very much.
You are a hero. You are.
No, I'm not a hero. I'm just a doctor. No.
A superhero. So, any other question, or do we want to conclude?
I would be happy if I just could put a little question.
Yeah, sure.
Because it really touched me. As in your presentation, you spoke about listening the patients. And, there are a lot of emotions, expectation, frustration. Every woman, every person brings his personal story with him. And as an expert doctor, how would you say it is important in the taking care of lipedema and the relationship and the emotions, the psychological aspect? How much is it important in your opinion as expert?
First of all, let me point out that there is first a biological changement lipedema, and maybe, just maybe, there can be afterwards a psychological problem. If these young ladies in puberty see what they are looking, how they feel, how the others look on them, and they are in the vulnerable phase of puberty and they do not agree what happens with their body. This might lead to a problem. Yes, might, but not typically. So I disagree with all these arguments that there are 82% of ladies with problems and psychological things. I do not believe this, even if it's published by the group, you know whom I mean. I don't want to call it. So Necessarily, I like to tell you what I do. When patients are coming to me, and asking me, Doc, have a lipidem, yes or no? I will do what I showed you, the first look in distance and so on. And afterwards, she's close again. Yes, I'm talking close again. Then we sit together and we have time. First necessary time. Then I explain what I think. And I explain how there are two things, genetic and non-genetic lymphatic. And I explain to these genetics, and this is, you didn't do anything wrong. This is not your fault. Quite often, there are sitting ladies from 50 years age. They begin to cry because they say, you're the first who believes me what I am telling. Yeah. Most of these ladies know that the doctors and the rest of the world does not believe what they're telling. Even if they are thick and they say, I did all my exercises and diets, then the answer is, yo, you did the wrong exercises, you did the wrong diets. Yeah? And even they are thin, they're asked to do more exercise, more diets. That is stupid. Doctors have to come back to believe what the patients think and what they tell. And then, if it's not conclude, I will say, I do not believe this. If there's a lady with 160 kilograms and she tells me she does not do any breakfast, I do not believe her. Very easy. But the first of all in lipedema is you have to say then that you did not do anything wrong due to the lipedema. Not to anything else of the life, due to the lipedema. And this was the first point where they will first time feel that you are truly with them as a doctor and that you're listening and that you like to solve the problem. And then you begin to talk how you can solve it, consulting and so on and so on. This is my way. I do it all the times long. And there were lots of ladies who wanted to marry me afterwards.
Yes.
So be gentle to these ladies.
Yeah.
You have to listen to them. They have an illness. They are not talking white-mouthed over their problems. You have to listen between the sentences. Just listen in it and take your time. And then you will find a good solution for it.
Thank you. I think after this answer, you are not only Sherry's hero, you are the hero of all of us.
And also Kate is also saying the same. So.
A very super take-home message, because by disbelieving patients, you worsen their pain. This is a message that we want to deliver at home for all the lippy ladies that are listening to us and need to be believed and treated. So thank you very much, Doctor.
Thank you.
You're welcome.
Thank you.
I have a super very last question that was about actually vascular compromise in lipedema, but especially referred to ways of reducing pain in lipedema by non-surgical measures, especially for young women, adolescents, teenagers, and young children. Because many lipedema ladies have 14 years old children who started to show symptoms, but of course they didn't want them to undergo liposuction at the age of 16.
I do not agree. My youngest child was 13, and I did the surgery because the patients came with her to me and she was exploding. Yeah, you could see the damage of the skin in her. And I explained to these patients, it's too young. She should be older for doing the surgery. But then I looked more on the paper in my brain. I said, okay, we can try it. And I told these patients, maybe she will come again afterwards, after her adults in 25, when she's 25. And she came 10 years later, and she had a wonderful life up to there without any stockings and any compression and any pain and any drainage. Oh, so I think it's a question of doing surgery as quick as possible and as early as possible, because you take them away from the necessity of conservative treatment. This is the second way you can treat it, so conservatively. Now think on this 14-year-old nice girl, which would like to go to the beach or somewhere else, and she's always in stockings, and she has to have a date with her physiotherapist and not with her friend, And that's is damaging her social and maybe a sexual life. Maybe, I don't know. But the first will be to decide this and to discuss it with the patients and bring her to a good solution. If she is able to do it with conservative treatment, and she says, when I go to the physiotherapist and when I do my stockings, I have less pain, great. But when you want to bring it out of the conservative treatment, there is no possibility, no other possibility than to do the surgery. And I would recommend it to do it as quick, as free, to early as possible, so that they are free from the problems and have another way of becoming older and another way of life without all these lipedema problems. That's the idea.
Thank you very much. And this will be particularly interesting for our next webinar that will go next Thursday, in which we will have two teenage patients, very young lipedema patients, Margarita and Georgina, who will speak about how to manage lipedema in their teens. So it will be super interesting. So please stay with us and see you next Thursday for next webinar. Now we're closing, so I think we should thank Dr. Cornely for staying with us. A lot of greetings to our followers, and a special thank to Kate and Sherry that are monitoring questions and following us. Next webinar will be with them. So Dr. Cornely, one last sentence for our followers. What do you want to say before leaving?
Anything was said, you know what you're talking about, go ahead and feel free to do anything you like. It's just a lipedema, nothing else, and you can solve it.
Thank you.
Thank you very much.
Thank you very much.
Bye-bye to the audience.
Bye.
Thank you.
Bye-bye.
See you next evening.
Have a nice evening. Bye-bye.
Bye.
Dankeschön.
Oh, ja.
Schönen Abend.
Tschüss.
Liebe Grüße nach Köln.
Mache ich sehr gerne, natürlich. Frau Schömedin, vielen Dank. Tschüss.
Bis bald. Tschüss.
Schicken Sie mir noch einen Link für das Meeting nächste Woche? Ich habe diesen noch keinen bekommen.
Dobbiamo mandare il link per la prossima settimana.
Ja, va bene.
Ja.
Yes, we have the link for next Thursday.
Wir machen das auf jeden Fall.
Vielen Dank und schöne Grüße an Sherry, wenn sie noch zuhört. Tschüss.
Ja.
Bye-bye.
Mit ganzem Herzen. Bye. Tschüss.
Bye-bye.